Good afternoon. I am Tiffany Willoughby, Assistant Director of Education Programs and Outreach in the Office of Research and Innovation at the University of Texas at Dallas. Thank you for joining us for a COVID-19 conversation, Data Trends in North Texas. Today we welcome Dr. Timothy Bray, Director for the Institute for Urban Policy Research at UT Dallas, Dr. Lea Aubrey, Director of the UT Dallas Student Health Center, and our moderator, Vice President and Chief of Staff, Dr. Rafael Martín. Dr. Martín, the virtual mic is yours.
Thank you, Tiffany, and welcome Comets and friends of UT Dallas to this conversation this afternoon. It's my pleasure to be here and to welcome Dr. Bray and Dr. Aubrey for what I hope is going to be an enlightening conversation. To kick us off, I'm going to ask Dr. Bray to review some of the work that he and his team have done to help track the pandemic and some of the statistics associated with it, especially as it pertains to our public health environment here in North Texas. He and his team have created a tool that we at the university have utilized extensively, and I know that others in local government and in the business community have been using it as well to track the pandemic and help in their decision-making process. So with that, let me turn things over to Dr. Bray to review his tool and his team's work. Tim.
Good morning, Dr. Martín, and thank you for having me. The tool you're about to see is actually a tool that is available to anybody in North Texas. It is the North Texas COVID data viewer. And we're going to use that today to fuel our conversation about the statistical updates that Dr. Martín asked me to show you. So let me show you first the numbers. All right, now this is going to load God willing, a virtual version of our dashboard. Green means good, red means bad, is a sort of a traditional reference. So new cases in the last 7 days, this is in the North Texas metropolitan statistical area. 98,563 new cases in the last 7 days. This is down 20% from the week before. Now we're seeing a steep decline in new cases as averaged over the 7-day period because we've peaked or plateaued more than likely with respect to COVID-19 and the Omicron variant. You may have heard news this morning about a subvariant of Omicron, which is called BA2. We'll talk a little bit about that at the end. 211 deaths, 259,000 active cases. Our active cases continue to go up. Basically, a case is active for anywhere between 10 and 14 days, depending upon how symptomatic someone is. This is a statistical definition, by the way, not a medical definition. So that number will continue to go up until our new cases fall off for about 2 weeks straight. Hospital occupancy is up 97.5%. ICU occupancy. We'll talk a little bit more about what those hospitalization numbers mean. But before we go much further, I want to show you a trend. And this is, I think, something that is important to keep in perspective. So let's take a look at the state and county trends here. All right, so the top left panel that you see here, this is active cases by date. All right. And you saw that we had the peak in the fall. This was the beginning of our fall semester. This is this is state of Texas data, but look at how far we've come up with active cases in Omicron. And more importantly, it's the rate of growth that we see with Omicron that has really challenged our healthcare and public health environments. You saw when we had our October 2020 to January 21, our sort of first COVID peak in North Texas, we had a very gradual decline. It took us almost 2 months to peak. Here we've peaked in a matter of about 3 weeks. So this is a real challenging situation. Of course, the dashboard is available to you. I'm sure Danny or Tiffany will put the link in the chat, but it's at utd.link/COVID-dashboard. Let me talk about a few other things that are important for us to keep in mind as we're weathering this pandemic. So Roy Rogers used to say, it's not what we don't know that hurts us, it's what we know that just ain't so. And a lot of times that's the case with what we understand and see about hospital statistics, about public health statistics. So I want to talk a little bit about the data you just saw in the context of what we know to be going on in the rest of the world, or the regular business world. The first sort of tenet for us to think about: normal business still goes on. We still have busy days and slow days in the hospital. We still have busy seasons and slow seasons in the hospital. And I'll show you here on the left-hand side of the screen, and let me get my laser pointer out here. You see here that we have a total hospital occupancy by date. And it turns out that, you know, we rose and rose and rose, and then we see this huge divot. Well, this is Christmas. Everybody goes home at Christmas. We're not scheduling optional surgeries. People tend to avoid the hospital at Christmas. This, by the way, is the tail end of Thanksgiving at the beginning of this chart. We peak through early and mid-December. We go down at Christmas. We come back up. That has nothing to do with COVID. That is entirely the regular day-to-day operation of the hospital. We even see a similar plan here in ICU beds, right? So ICU trends, we still see the divot, but not nearly as much. It's harder to get out of the ICU than it is out of a general med surg bed. But I bring this up to say normal business practices still go on, even in the light of COVID. We still deal with staff shortages. We still deal with seasonal outbreaks. We still deal with workplace injuries. We still deal with all of these other trends that happen in our communities. The second point, we need to understand capacity. I bring this up because if you look here, this is data for Dallas County from today. There are, on the right-hand panel, you see we have 614 ICU beds, and we have 601 ICU patients. And that means, when some people read this chart, that means we have 13 ICU beds. For starters, there's very little difference between an ICU bed and a med-surg bed. What differs is the way it's staffed and the way it's equipped. Now, what you're seeing, those 614 beds are staffed ICU beds. We actually have more physical capacity than this. So when we see these numbers and we say the hospital is at 98% for a hospital occupancy rate, and that means we don't have any physical capacity left, that's not the case. Where our challenge isn't brick and mortar. Our challenge is in keeping staffing available to these facilities so that we can receive casualties, receive injuries, things like that. So understanding capacity is a big piece of this. That's why even at 98%, you're not seeing tents up outside of hospitals. We still have bed capacity in these hospitals. We just don't have nurses, doctors, techs, dietary, etc., able to staff them. Third point. The big difference with Omicron is that case volumes are 2 to 3 times what they were with Delta. Now, we bring this up because you've heard widespread the story that Omicron is less serious of an illness. It's especially if you're vaccinated, you're far less likely to require hospitalization. The illness itself is less likely to result in hospitalization, less likely to result in serious injury, and yet there's all this talk about our hospital utilization. So think about it like this. If the percent who need to go to the hospital goes down, but the number of cases triples, our fixed capacity still gets saturated. And as we pointed out before, we see this steep rise, literally from right at the sort of right around Christmas to 1 million active cases in the state of Texas by the 3 weeks later, right? This is a fantastic increase. And it stresses that it's not just about our sort of snapshot capacity, it's about the elasticity with which we are able to respond to shocks to that system, all right? And that's something we are, as we're learning from COVID, we're coming back and saying, how do we need to change things and do things differently? Lastly, the fourth point, this is a nice little graph. It's available from the dashboard that shows you North Texas counties from the date of first exposure. Most of us in North Texas, it was the end of March that we saw our case. Everybody climbs at the same time, but we climb at different rates. So this is an important piece for us to understand. Public health policy in Texas tends to be mitigated at the county level. And we saw this very early on with COVID. We saw that Dallas County was one of the first to shut down bars and restaurants. Collin County was very slow to do that. As a matter of fact, it was cities in Collin County that moved before Collin County did. The net result of that was everybody who lived on the Dallas County line aside of Richardson just drove to the Collin County side and went out to eat there, even though regionally we have a regional problem. So that's why we see these sort of variations in these numbers. I point out Hunt County and Tarrant County and Denton County in these graphs because in each of those we had a specific, in Tarrant and Denton counties, they were state hospital type stories where we had these big facilities that got impacted that changed their local dynamics, right? So even though the virus behaves the same way in everybody, the systems in which that virus operates, the communities, the businesses, the hospitals, the public healthcare systems, the schools, vary widely in how they anticipate that. That impacts virus transmission. Last thing we want to talk about, at least for my presentation today, I want to talk a little bit about what we know about BA2. Now, about a day ago, we learned that there is what's called a subvariant of Omicron, and it's called BA2, and it's not BA Baracus, right? This is the Omicron subvariant that was first reported as early as December 10th, 2021, and then just, I guess, 5 days ago now, the UK named it a variant under investigation. I want to talk about BA2 because it's important that folks understand there are hundreds of variants of this virus. Very few of them are variants that rise to a level of that CDC would call a variant of concern or a variant of high consequence, right? Variants of high concern and high consequence, we'll talk about in a minute, but those are things like Delta and like Omicron. So the mere discovery of a variant shouldn't be unexpected. We know that viruses as living organisms mutate, and over time, most viruses mutate to become more contagious and less deadly. One of the things that you'll see people alarmed about with respect to BA2 is that the mutation in Omicron, which they now call BA1, the big mutation was a mutation on the spike protein. Without getting into the science of it, the idea here was we could tell who had Omicron by looking for a what's called a spike failure, right, in the test, a spike target failure. What that showed us was this particular test. Now, this is not your standard COVID test. This is what gets done in the laboratory to figure out how prevalent different variants are. It was easier to find Omicron, but BA2, the spike protein is back. And so the challenge is this simple test to figure out if Omicron was there is not so simple anymore because we now have it looking like Delta under the microscope is a very simplistic way to say that. So I want to close by just reminding you with super tiny print what's going on here with the lingo. All right. Now, we talk about COVID variants all the time. Omicron, Delta, Alpha was an early one. Gamma was an early one. Mu and Iota have been out there. Kappa has been out there. Most variants that we're thinking about are called variants being monitored. It's a variant that exists. We know that it exists. It shows up in the lab tests. It's not any different really from other variants. So what the CDC says is these do not pose a significant and imminent risk to public health in the United States. Most of the variants that we talk about are variants being monitored. Some, like BA2 in the UK, is now a variant under investigation, or what in the US we call a variant of interest. We're looking at this variant and saying, something's going on here. We don't know yet if it's going to be any different at all from BA1, but it's worth taking a look at. There is no evidence whatsoever to suggest it's anything we need to worry about yet. If it is, it will move to a variant of concern. Usually we move something to a variant of concern because it's more likely to be spread easily, an increase in transmissibility, or as we saw with Delta, an illness that could be more severe, or increase in hospitalizations or deaths, or something like Omicron that's not as easily defended by our current measures, for instance, masks and vaccines. All right, I bring this up because if you just watch the news, it's going to be very easy to be concerned that, oh no, there's a new variant around the corner. Well, there have been new variants around the corner every week. Most of the time, you just don't hear about them. And the main reason you're hearing about this one now is because it's not as easy to detect that the virus is Omicron versus Delta. For most of us, it really doesn't matter. If you have a positive COVID test, stay home. Get appropriate medical help, right? It doesn't really matter if you know for a fact that it's Omicron or you know for a fact that it's BA1 or BA2. Now, that doesn't mean we dismiss the threat. It simply means that we're cautious about overreacting and running out because it's the end of the world because there's a new variant. One of the things we'll have to get used to is living in a world where these variants come out just like variants of the flu virus every year. So the more comfortable we are with the language, the more comfortable we are with understanding what's being communicated, I think the better we'll be in responding as a community. And with that, Dr. Martín, I'm happy to turn it back over to you.
Well, thank you, Dr. Bray. A couple questions that occurred to me as you were making your presentation. Could you talk a little bit about the number of active cases? And I'm assuming that the numbers that you're showing on your dashboard are confirmed cases, and the number of cases that public health officials actually believe are in the community. So active cases, but perhaps untested or undiagnosed cases. How that number compares for the Omicron variant versus some of the earlier variants we saw in Delta and Alpha.
Absolutely. So as you remember, the big concern about Omicron was that the symptoms were so much more like regular allergy symptoms or a common cold that people would not even know that they're sick. And in fact, that's many of the stories that we're hearing. People had no idea they were sick. They went to take a trip, took a test, and found out they were positive. Because of that, there's a multiplier that we use. Now, it's not a terribly scientific multiplier, but with early Delta, we were talking about maybe 4 cases for every 1 case that we knew. Now we're talking about maybe 5 or 6 cases for every 1 case that we know of, right? So because people either aren't getting tested or have no idea they need to be tested because they're not experiencing any symptoms, we do believe that there are a lot of cases out there that we just don't know about. But yes, the cases reported on the dashboard are the cases that are lab confirmed positive cases.
Thank you. A related question actually from one of our audience members. So who says that she and her husband both tested positive with an at-home test. So with those tests, those positive cases, which I'm pretty certain indicate that you do have an active case of COVID, would those be counted in the numbers that are reported on your dashboard?
Only if that person was then talking to their healthcare practitioner who reported them to the county and the state. So there's no, that's the downside, if you will, from a monitoring standpoint is there's no closing the loop on those at-home tests. Those at-home tests don't go back anywhere, right? If you follow up with your physician will make the appropriate notifications. But the plus side, which I think far outweighs the downside, is you can find out without going to your doctor, and you can on your own quarantine and isolate and make sure you don't get other people sick.
Very good. Well, thank you, Dr. Bray, and I'm sure we'll have some more questions from the audience here before the end of the program. But I'd like to go to Dr. Lee Aubry, the director of our student health services here at UT Dallas, and a member of the team that has been working diligently throughout the pandemic to keep our community safe. She's been a very trusted advisor and someone who has lent her expertise to our response. And I would like to turn the mic over to her for a little bit just to talk about the latest in what we know about how we can protect ourselves, what we should be doing to keep ourselves and our families safe, and any other advice you may have. So, Lee, over to you.
Thank you, Dr. Martín. So again, just to take a moment to share action items, which we've all heard, and I apologize for repeating, but I think sometimes we need to hear things more than once so we can take heed or either share them with others. And so just to start off, action items to take if tested positive for COVID. I think Dr. Bray hit the nail on the head. Just sometimes we test positive. Well, those who have tested positive have no symptoms, have no idea that they are sick. If you have a positive test result, no symptoms, the suggestion is you stay home. Do not go to work, do not go to church, do not socialize with others. So I think often it's mistaken that I don't feel bad, I should be okay going out. We definitely want you to take the necessary precautions and stay home for the recommended isolation period and then follow up with your medical provider. For those of you that test positive and have symptoms, some steps I suggest you take is to consult with a medical provider for possible treatment options. Isolate yourself from others, possibly in a private room, utilize a private bathroom, avoid common areas. Again, that's protecting your family and other, our loved ones to make sure that we keep them safe. In regards to food, definitely have food delivered or have someone pick it up and drop it off at the door. Same to do for medications, have someone pick it up. There are a ton of pharmacies that deliver medications. Again, just taking precautions to keep yourself healthy and others. Another big thing is to notify close contacts. I think, we got really excited around the holidays and we were so excited to see others that we just shared the love, and among that shared COVID as well. And so it is necessary that during those times of gatherings, if you do receive a positive test result, it's necessary to notify those individuals so they can get tested as well and to protect themselves and, protect the ones that they're around all the time. I think a big misconception for our university around self-reporting, people are fearful of doing that, but it's so important that we have those numbers so we can keep track of what's happening on our campus. But then also it allows our contact tracing team to provide you with resources. Maybe you need assistance with food delivery or medications, or in the instance for our students, possibly assistance with coursework, notifying your professors that you're going to miss class. And so there's a way. We have policies and procedures in place for those things. We just definitely need for you as the UTD community to take advantage of those resources that we have available. And then, again, we've talked about testing just a little bit. And so the university will conduct symptomatic testing, and that will be scheduled through your contact tracer. However, President Biden announced that we're going to have home tests available. So we definitely want you to take advantage of that. Those are free of charge. For those of you who have already done it, great. For those of you who have not, we'll definitely make that link available so you can access it. You get up to 4 tests, and it's 4 tests per household. And again, like Dr. Bray said, once you get those results, you definitely want to follow up with the provider, because that's what in the medical industry, that's what our job is. We notify the correct individuals so they can, again, keep track of the numbers within that area or location. And then, just reminders that we see around the campus, and even as we go out in the communities, wear your mask. It is so important that you wear your mask, whether you're vaccinated or not vaccinated. Again, just to keep yourself protected and, not knowing what's next. We know that there's always another variant around the corner, but it does assure or reassure you that you are taking the necessary precautions. In addition to that, continue to wash your hands, get vaccinated. If you have not had your booster, boosters are readily available just about anywhere. It is simply clicking on to a site, making the appointment, and showing up and making sure that you take care of that. If possible, avoid mass gatherings. Again, social distance as possible. I think, we have definitely kind of slacked off on all these precautions that we've had 2 years ago. when everything started, we kind of jumped on the gun and did everything, but then now we've kind of gotten a little bit lax and just comfortable. And so we need to make sure that we revisit those things to keep everybody safe. I think another thing, CDC has shared their changes in recent isolations, and individuals are really excited about that because we know how isolation and quarantine made us feel. But even at the advice of the CDC, there's that 5-day cutoff. But remember, make sure that you're feeling well before you return, because if you're still having symptoms, you're not doing anybody any justice by returning to work, returning to school, returning to whatever event that you decide to go to, and you're still not, absent of fevers or symptoms within a certain amount of time period. Again, a lot of this is repetitive. We know it, and it's so important to make sure that we follow the guidelines. We know they work. We've definitely seen, even in the health center, a very, very low number of flu cases reported. I think I shared with our afternoon group that I think in December we had 3 total flu cases, and we normally have way more than that. So the advice is there, is definitely helpful. And so again, I'm just here to remind you of the precautions that are there, and just making sure that everyone takes heed to keep themselves protected, keep others protected, and just do our best to keep UTD safe as a community. Thank you, Dr. Martin.
Thank you, Dr. Aubrey. A quick follow-up question for you. Could you speak a little bit about the vaccines that are available for COVID-19, and just remind us of their efficacy compared to, vaccines for other common illnesses like the flu, and also speak a little bit to whether or not people who have tested positive, who have had a confirmed case of COVID, but may not be vaccinated, should get vaccinated even after they have tested positive for COVID.
Sure. So in the Student Health Center, we are offering the Moderna vaccine. And so what has been great and what we've seen over the past months is, even now, if you previously had Johnson & Johnson or Pfizer, there is a waiting period for each vaccine in which you can mix. So if I initially had Moderna and I go to a location where they only have Pfizer, I'm able to get Pfizer as my second or my booster. Again, just consulting with the medical provider. There are certain restrictions for each one, a time lapse between the doses, to make sure that you get the most amount of coverage from that vaccination. When you think about, if we think about the flu vaccine, every year there's a prediction of the strand that we'll see the next year, whether it be A or B. But the idea is the flu vaccine provides you an amount of protection. So should you get the flu, for instance, it's not as bad. And that's definitely what we've heard from individuals that ended up getting COVID-19 and they've already been vaccinated. The symptoms were as bad, or, we're walking around not really knowing that we're actually sick, and we are. And so even those individuals that maybe did not complete their series and they ended up contracting COVID-19, the advice is that you still get vaccinated. And again, it is based on the time of when you initially were infected with COVID-19 and when the symptoms subsided. So just consultation with your medical provider with that, and they'll be able to give you a better timeline in regards to receiving it. So, the information that we receive on a daily basis is not for naught. It's definitely to help us be better, to be better educated, and then also, not to hold the information in, but to be willingly share the information with others. I think as more people share their experiences with COVID, a lot of times that encourages others to go ahead and get vaccinated. We still have a lot of people that just have not been vaccinated, but sometimes it takes for those individuals to have an incident that really hits close to home and for someone to share their experience. And that's the push that they need to, take care of business and get vaccinated.
Thank you, Lee. Another question concerning the symptoms that you were discussing. I mean, there's been a lot of discussion, as Tim mentioned, that the Omicron variant produces less severe symptoms than previous variants. But I wonder if you could talk to our audience a little bit about, when they should seek advice from their medical care providers, for students who are on campus, when they should seek an appointment from the Student Health Center, and for those others in our community, what level of severity should they be concerned with, and maybe cause them to go seek urgent care or maybe even an emergency room visit?
Correct. So, I mean, my advice is immediately, as soon as you know that you've been exposed, we definitely want to encourage individuals to get tested. As soon as you start displaying symptoms, definitely make an appointment with a healthcare provider or urgent care. And severe, I mean, because we think about it, it's viral. So ultimately, they are providing you with treatments that are treating the symptoms, but everybody has a different medical history. We have no idea of how COVID is going to impact one person from another. So, everybody's level of severity may completely, definitely be different because based on our medical history. So the advice is, definitely immediately seek medical attention so you can get the correct treatments that will be provided for you as an individual.
Thank you. Let me turn to a couple of questions from the audience, and I will try to answer a couple of these. One has to do kind of related to the at-home testing and whether or not we are counting those in our daily number of positive cases. I think Dr. Bray answered this, in terms of the North Texas region, but as an institution, I can tell you that yes, if you're completing your daily health check, if you're completing a self-report form as a member of the university community and telling us that you've tested positive with an at-home test, we will count that as a positive case as it relates to our campus community. So this gives me an opportunity to once again plug the daily health check. All of you should be receiving those daily emails or texts. It's very, very important to us that you complete those on a daily basis. It is the single best source of information we have about the risks and the number of cases we have in our campus community. And it really does help guide our decision making in terms of how and when we return to campus. Another question concerning recent advice from the federal government indicating that that N95, KN95, KF94 masks are more effective against transmission of the Omicron variant. So these are high efficiency masks that are pretty widely available now. And as Dr. Aubrey mentioned, as with the at-home test, the federal government is going to be providing supplies of N95 masks to pharmacies and other places for distribution at no cost to individuals. The question is, are we going to be providing N95 or equivalent masks to folks on campus? The answer to that is no. We will continue to provide 3-ply surgical masks to those on campus. We do encourage those who have access to N95 masks to go ahead and wear them on campus. But I will reiterate something that Dr. Aubrey said, which is any mask is better than no mask. The higher efficiency, either the surgical masks or the N95 or equivalent masks are obviously better than a cloth face covering at this point. But more mask wearing obviously will help us decrease the risks of transmission in any in-person setting. And so we would encourage you to wear whatever masks you have available and take advantage of the N95 masks when and if they're available to you. With that, I've got a follow-up question for Dr. Bray concerning kind of differences in the Omicron and previous waves that we've seen during the pandemic. So if I recall correctly, Tim, earlier waves hit different parts of the country at different times. And one of the things that allowed us to do was to move resources from one region to another, especially as it related to nursing and hospital capacity. Has that been different for the Omicron wave? And if so, what sort of impact has that had on our ability to respond?
So one of the things, and that's a great point, one of the things that's different about Omicron is the transmissibility is higher, and the length of time from contact to symptoms is shorter, right? Which means it moved like wildfire through the country. Whereas with Delta, we could see even as much as a week or two between when we had onset. Basically, within a period of days, everybody had Delta showing up in their region. And once it was here, it was moving very, very fast. So the net impact of that, coupled with, by the way, the fact that we've changed some of those federal programs. So you'll notice, like when we were dealing with Delta and Alpha and Gamma, we had convention center space, we had federal medical units. A lot of that had been spun down over the summer. And the thought was, well, given the way these infections are unfolding, our hospitals had figured it out. This came so fast and like lightning that it really did incapacitate a lot of our facilities. And because it was so contagious, our healthcare workers were catching it, right? So, you know, the sort of the typical protocols by themselves were not even insulating our healthcare workers, because they would go to the grocery store, and even though they were wearing a mask, they caught Omicron. So yeah, it slammed us quite literally.
Yeah, I think you bring up a good point, and Lee, I don't know if you wanted to kind of just discuss the impacts that the latest wave have had on, you know, just your staffing in the student health center, but it does illustrate the greatly increased transmissibility of Omicron. Many people who have tested positive are fully vaccinated, boosted, right, and still have caught it, which, you know, most of those people don't have severe symptoms, certainly don't require hospitalization, but it does take them out of the game for a number of days. How has that impacted, Lee, your staffing, your ability to kind of provide services to the campus community?
We definitely saw exactly what Dr. Bray shared, because our health center, you know, we never completely closed. We've been providing care this entire time. The thing that was our saving grace is that we split our staff. So we had like an A staff and a B staff. So it's almost like when one team got hit, then they were rotating out. But it's almost like when we came back from Christmas, it was almost like a domino effect where we had gotten down to about 2 nurses. So we had to be really intentional with how we scheduled. And so you think about it, we had those students coming into the health center that had no symptoms. They felt great. They'd probably just come from somewhere on another part of campus and they test positive for COVID. And unfortunately, you know, with our staff having that day-to-day contact, they contracted it very easily. We had maybe 1 or 2 that had to go to the hospital because, again, tying back to what I said, underlying conditions, pre-existing conditions that kind of made it, you know, a more escalated condition than what someone else would have experienced. And we had others that had no symptoms and pretty much, you know, they were in isolation. Because, you know, the students and the patients are still coming in and we have a service to provide, but we're on the back end of it and all the healthcare workers are really, really being impacted by it.
Yeah, we have had a similar experience with some of our other frontline workers. Our police department in particular had similar experiences, and it does put a strain on some of those resources. And again, it illustrates why we all as a community have to try to do as much as we can to reduce our own risks so that we don't become a potential transmission risk to others in the community, and try to take some of the pressure off of those critical resources. Dr. Bray, can you talk a little bit about testing and kind of the positivity rates we've seen from testing in this current surge versus, again, previous surges?
Sure. One of the things that's important to recognize with tests is different tests do things differently, right? One of the earlier tests that we've had, the tests that we use are PCR tests. These are laboratory tests that will detect even a small amount of COVID in the body, so i.e. early infection. The rapid tests that are out there, the home tests, are antigen tests. The difference being that the antigen tests are better equipped to handle someone who is in the throes of sickness. If you're very early in COVID, that antigen test has a chance of giving you a false positive, a false negative. In other words, telling you you don't have COVID. But it's simply because there's not enough of it yet in your body. So if your friend calls you and says, yesterday we were having dinner, today I tested positive for COVID, there's a chance that if you go real quickly and take a home test, you're not going to get a positive, right? You're going to wait a couple of days and see what's going on. The advice, therefore, is if someone's told you that, don't go take a home test and say, aha, I don't have COVID. Go ahead and isolate for a couple of days, right? The university is equipped to help you get through this, so we'll work with you online, things like that. The other piece that I know someone had asked in chat talking about testing, you know, how do we know how prevalent one variant is over another. In Texas, and especially here in North Texas, independent labs like UT Southwestern, they screen 100, 200, 300 samples a week looking for the genetic differences that make one variant or another. And then they look at that as a percentage. You know, by and large, for the most part, almost exclusively in the US, Omicron is 99% of the tests that we're seeing right now. But we look for that to change over time. The point being, your COVID test doesn't tell you whether you got Omicron or Delta. And it's not really safe yet that you could say, well, I didn't get bad symptoms, so it must not have been Delta. We do still have some Delta infections out there. So it's not a safe bet to say I can tell which one I had based on the symptoms that I had.
Dr. Aubrey, another question from the audience. I think you may have covered this, but it bears repeating. Could you tell us again, should people who have tested positive in the past get vaccinated subsequently if they're not vaccinated? And maybe take this opportunity to let our students know what their opportunities are to get vaccinated through the Student Health Center.
Yes. So the answer to that question is yes. You're definitely encouraged to get vaccinated after a positive COVID infection. Again, just referring to your medical provider so they can calculate the time in which the COVID infection started until the time that it subsided. So you have the amount of time lapsed there to get the vaccination. On our campus, our students can definitely get the COVID-19 vaccine. They can do that by visiting the Student Health Center website. There's a patient portal link there. If you click there, you can use your Galaxy credentials to log into the site to make an appointment. There's some questionnaires, so we better understand how we need to accommodate your COVID-19 vaccination questions, specifically, as I addressed earlier. If you perhaps were vaccinated by Pfizer or Johnson & Johnson, again, we just want to make sure that we have the correct time lapse there to make sure that you're adequately covered once you receive the Moderna vaccine, which we offer in the Student Health Center.
Thank you. Another question from the audience that I will take a crack at answering, but then I will invite Dr. Bray and Dr. Aubrey to weigh in. So the question is essentially, how do we know that symptoms are less severe for folks who've been vaccinated versus those that have not been vaccinated, especially for a variant where we have seen milder symptoms than in the past? And I guess my response to that question would be kind of referring to a report that was released by the CDC last week, indicating based on essentially hospitalizations due to the Omicron variant. And what those numbers showed was that for those 65 and older, you're about 50 times more likely to be hospitalized if you were unvaccinated versus being vaccinated. And for those in the 50 to 65 year old demographic, that number was 44 times more likely to be hospitalized if you were unvaccinated versus vaccinated. So, I think that gives a pretty clear indication. It does not mean that if you're vaccinated, you cannot develop severe illness. You certainly can. But the likelihood that you're going to develop symptoms that require you to seek hospital care is much, much less. I mean, significantly less than if you're unvaccinated. So anything to add to that, Lee or Tim?
I mean, I would just add also just the testimonials. You hear people talking about their experiences and just, even hearing feedback from the doctors where it really could have went left and someone could have been hospitalized to the point where it was really mild or it was more flu-like. So it was something that they were able to manage at home and that they did not need to be hospitalized. So I definitely lean into the feedback that patients give from their own personal experiences and even sharing, what if I had not been vaccinated, what that possibly could have looked like.
Another question from the audience concerning treatments that are now available for COVID-19 patients. And Dr. Aubrey, maybe you could comment on what those treatments are and how individuals who test positive would be able to access those, whether it's through their primary care providers or whether it requires hospital care?
I think the treatments that they're speaking to are those that you're going to see at the hospital level. Again, your medical history and underlying conditions is really going to predict or determine what you can actually receive in regards to treating that. What you'll see more on the clinical side is it is a virus, and just like any virus, there is no cure. You have to treat the symptoms. Even if the common cold, we can't go and just pick up something over the counter and it's going to be an end all be all. You know, we push vitamin C, zinc, all these things that really treat the different symptoms. And so, you know, we've seen where people have dealt with a lot of sinus related issues. And so looking at a person's medical history, what can they take? I can't just tell them to take, you know, Mucinex. We definitely want to kind of look and see what, based on their medical history, what would be the most viable option. So that's always why we're pushing, you know, should you have symptoms or if you have a confirmed positive COVID-19 test, to reach out to your medical provider so they can get or they can create a treatment plan for you that will work best and make you have the best health outcome.
Thank you. Dr. Bray, question for you, and at the you know, at the risk of being accused of having buried the lead here, you know, not addressing this sooner, do we think we have seen a peak of cases in North Texas? And if so, what do we expect to see in terms of the case numbers in the coming weeks?
That's a great question. I'll answer that in sort of two parts. One of the numbers that we look at is the reproduction number. And the reproduction number tells us how many people does each infected person get sick. When that number is less than 1, it means the virus is going away. When Omicron was taking off, we were at 1.3, 1.4 in the general population. We're now down to about 1.03, 1.04. Now, the numbers are still high, but the rate of growth, which is what our sub T tells us about, has started to level off. We have at least plateaued. There's a chance, depending upon what happens over the next 4 or 5 days, that we're actually beginning to go back down. Now, if our pattern follows the pattern that was seen in South Africa, we would expect to have a general downward trend that's punctuated by a few slight peaks. Goes down, comes back up just for a little bit, goes down more, comes back up for a little bit, 2 or 3 times over the next, say, month. But you know, we have at least plateaued. There's a good chance we've peaked. One of the concerns that's out there is we may not have peaked among adolescents because so few adolescents are vaccinated. Now, you know, even though the Omicron dodges the vaccine somewhat, we have a big chunk of the population that doesn't really have those protections that a high percentage of adults do. So we may still see pediatric cases go up.
Very good, thank you. A question for the audience that I'll try to tackle here, relating to you know, relating to mask wearing essentially, and since there are you know, less severe symptoms from the Omicron variant, and if you've been vaccinated, it's highly unlikely that you'll be hospitalized. You know, what is the efficacy of continuing to wear masks? And I want to thank the audience member who provided this question for this opportunity to respond. So my response to this question is that by and large, mask wearing is not about keeping yourself safe. It is helping reduce the transmission of the virus to other people. This is all about, you know, trying to reduce the impact of COVID on our community writ large. As a healthy, fully vaccinated, boosted individual, my risk from contracting COVID is relatively low. However, it is possible for me to have COVID, to have an active case, and to be transmitting the virus to other people. And the fact that I put on a mask reduces the chances that I then transmit to somebody else. And I don't know whether or not that person I'm standing behind in the grocery store line is immunocompromised or has some other medical condition that would put them at much higher risk. Those things are not clearly visible. And while they may be taking every precaution possible, what we have seen is that with this virus, the transmissibility is such that they may still get sick. And the consequence to that individual, obviously, is much higher than it would be to me as a healthy, fully vaccinated person. So that would be my response. I don't know, Dr. Aubrey or Tim, if you've got any other anything else you'd like to add to that.
I think you couldn't have said it better than I could. I think that's exactly what it is, and people need to understand exactly, what that impact is for you wearing the mask. Like you said, it's not protecting you, but it's just reducing the transmission. So there's a high efficacy rate, and we've seen it. We've watched it with our own eyes. So it's just kind of getting back to the basics as it deals with COVID.
And Dr. Aubrey, I'd say the proof is in the pudding. Look at the flu, right? We saw far fewer flu cases, if hardly any, last year, and it's mostly attributed to the fact that we were wearing masks. But masks aren't foolproof, but they reduce the risk, right? And it's possible that they reduce the risk less with Omicron than they did with Delta, but they still reduce the risk. So, all of these are steps, and I think that's what's important for people to remember is, nothing is perfect short of everybody going to school in a hazmat suit, right? But if we're not going to do full body respirators, every little thing that we do helps make a difference and keep some sense of normalcy.
Thank you both. Another question from the audience concerning misinformation about COVID and about the vaccines and treatments that are available to us. And the question is essentially, where do we recommend people go for the most accurate and science-based information? Well, I'll start this off and I'll let Dr. Aubrey and Dr. Bray kind of weigh in. Certainly our go-to throughout the pandemic as an institution has been the CDC. The Centers for Disease Control and Prevention are clearly the gold standard in the United States in terms of guidance on what we can do to protect ourselves, in terms of endorsing treatments and approving vaccines for combating this pandemic and other communicable diseases as well. So that would be the first place that I would go. I don't know if Dr. Aubrey, you or Dr. Bray have other suggestions.
So I would, because we're an academic community, I tell people to go read the journal articles. This stuff is everything you see on the CDC website, you can trace back to the journal article. And most of our students have the bandwidth to read these tables and understand and see what the weaknesses and strengths were with the study. But by and large, you can find it all there. The stuff I was talking about with BA2 came out of technical bulletins from the UK, right? The important thing is we don't find our information by just Googling it and taking whatever first pops up. Unless whatever first pops up, you can sort of vouch for the scientific accuracy of. We're a learned academic community. We should be able to do that.
And I was just gonna add, in addition to the CDC, we also get guidance from the American College Health Association for the Student Health Center. And again, a lot of people are looking to CDC and the World Health Organization. And so any printed material that we have in our office, we'll definitely put it in the hand of the students, because our struggle is always, like you said, Dr. Bray, struggling with someone who wants to Google everything. And so we want to make sure that they have the most accurate information. And so for us, sometimes it is giving them that printed material or pointing them directly to that medical resource so they can see and hear the information for themselves.
Thank you both. A question for Dr. Aubrey. What are the current recommendations on when individuals should be boosted if they've completed their initial course of vaccination? And does that vary based on the age and medical condition of the individual?
Yes, to all of the above. So there is definitely a time frame. As you've seen, we've seen where there's been, They're still doing research on individuals 5 and under. I know they halted that because there were some issues with the vaccine. We saw where our preteen or 5 and older, there was a time frame for that. So we do have to be mindful of that to make sure the vaccine is readily available to a particular age group. I know our individuals with underlying conditions and our frontline workers were kind of at the top tier because they were in the face of it every day. But again, I say circle back to your medical provider. But then also, if you have your vaccination card, hopefully you have a copy of that so you can see the dates. And then that way, the allotted time from between those 3 vaccinations.
And I know there's some discussion right now in the medical community about whether actually a second booster will be, efficacious against protective against, further spread. But as far as I've heard, that has not been made a recommendation by any of our public health authorities. Is that correct?
That is correct.
Okay. Just looking through some of the questions here and being mindful that we're getting close to the end of our time. Maybe what I'll do is just turn it back over to Dr. Bray and Dr. Aubrey and see if they've got any last words they'd like to share with our audience before we wrap up this event. I'll let you start, Dr. Bray.
Yeah, thanks, Dr. Martin. I think, conversations like this are useful because we've got to be in touch with this data and we have to understand it on a deeper level, right? We're moving from, hey, we've got this outbreak, we need to nip it in the bud and it's just going to go away forever, to a real understanding of it. We've got a new virus that's circulating and it's going to change over time and it's going to change the way we do life. And I don't know if any of you have had this experience, but I'm watching movies that were filmed in the 90s and 2 strangers walk up to each other and give each other a hug or slap each other on the back. And I'm like, oh my God, they're going to get sick. And I realized, wait a second, that was the world before COVID, right? We're going to have to really think about how we change the way we interact with one another, not in a bad way. This is, a lot of my own physician has said, I've wondered for years when it was going to be that we stop shaking hands. It's one of the greatest ways in the world to spread viruses. I just think really it's important that we don't react, that we don't Google, and that we don't sort of live in this state of fear. It's a medical condition. We know how to treat it. We're better at it than we were before. And we can do things to reduce our likelihood of getting it.
Thank you, Tim. Dr. Aubrey?
Exactly. People keep saying, when can we get back to normal? This is our normal. This is where we are. I think, not many of us were there on the cusp of the flu when it was a pandemic, and look where we are with the flu. We're living with it. It's part of what we do every day, and it's an annual vaccine. But if nothing else, COVID has definitely showed us how we can evolve and adapt during a pandemic. Everything, the mode of the way we do things have changed, but healthcare is still provided just in a more creative way through telehealth. Same thing with classes. Most of them are virtual. So it is about how do we adapt and pick up from here and continue forward. Because, just from a healthcare perspective, there's another virus, as Dr. Bray said, around the corner. And so we're going to have to be prepared for that and, adapt ourselves to what that looks like for day-to-day living.
Thank you, Dr. Aubrey. I'll just conclude by making a couple of comments about our community's return, to the new normal. As you all know, we've set February 7th as the date to return to in-person classes and a return to work on campus for those who need to be here. From what Dr. Bray has said, I think we are in a good position to maintain that date at this point. But we will be making an official announcement to the university community before the end of the week about those plans. And I would just like to say to all of our community members that I understand that there is some anxiety and trepidation about kind of returning to the new normal. And that I would just like to reassure you that we are doing all that we can to keep our community safe. We will have the same public health measures in place in terms of cleaning our classrooms, cleaning public spaces, availability of masks and wipes for classroom spaces. Please take advantage of those, and please be Comets United and take care of one another by masking up while you're on campus. If you're not vaccinated, please get vaccinated. If you're eligible for a booster, please get a booster. Vaccination and booster shots are clearly the best way that we can get through this to protect ourselves and protect our families and protect each other. And then wearing a face mask while you're in the presence of other people is a close second. So with that, I want to thank everybody for being here today. Thank you for your attention, and I look forward to speaking to you again sometime in the near future.